Hello, good morning, good evening, and good afternoon, everyone, from wherever you're joining us from. Welcome to this session, which is the third series of our genomic series on TB. So we're really excited that you could join us. Today we are going to have the first of our country experiences from Eswatini. We are really pleased that we have Dr. Vambe, who is a TB instructor at the Baylor College of Medicine. But before I introduce her, I just wanted to give us a few housekeeping announcements. This session, as you can see, is being recorded. And we're going to start with a presentation that will be for about 30 to 40 minutes, and then will be followed with a Q&A section. If you have any questions, please put them in the Q&A box and we'll address them during the discussion. And if we fail to get through all your questions, we will ask Vambe to respond to them and we'll send them out together with the presentation and the video of this session. We will also post the slides from this session as well as the recording on our resource page on the ASLM website, and we'll also share that link with you. If you require a certificate of attendance for this session, this will also be shared with you after this webinar. And if you don't receive that link, please feel free to reach out to us, and then that link will be reshared with you to be able to download your certificate of attendance. We have interpretation in French and Portuguese available. So please click the globe icon on your Zoom toolbar. You see a globe icon written interpretation. Please click on it and select either English, French, or Portuguese, and remain in that channel to receive interpretation as needed. So again, a very warm welcome to this session. And as I mentioned, this is the third in our TB genomic series, genomic sequencing series that we've been having. We've already had two sessions, one from Dr. Chikuse, who gave us a brilliant overview of the sequencing capacity that is available on the continent and what can be leveraged for TB genomics. He also provided the policies and frameworks that are currently being used to develop genomic strategies for the different countries. And we then had a follow-up session from Anita from the Foundation for Innovative and New Diagnostics, who gave us an overview of the sequencing technologies that are available, as well as the data that contributed to the policy recommendation from WHO. You may be aware that since 2023, WHO is now recommending that tNGS be used for the rapid diagnosis of drug-resistant TB. So we're now going to start delving into the country experiences to really understand how can we implement tNGS in our programs to be able to support the rapid diagnosis of drug-resistant TB and be able to reach that target of the NTB goal to make sure that all people with TB have access to universal drug susceptibility testing. So as I mentioned, we're really excited that we have Dr. Vambe, who is a distinguished public health specialist and a leader in the fight against drug-resistant TB. She has spearheaded key innovations in TB care, including the implementation of targeted next-generation sequencing in Eswatini, which has greatly improved diagnosis and treatment of people with drug-resistant TB. Dr. Vambe's contributions extend beyond Eswatini. She has impacted global TB elimination efforts. In recognition of her outstanding work, she has been honored as the 2024 Global TB Elimination Champion for exceptional contributions to TB treatment and care worldwide. She currently serves as instructor of pediatrics at Baylor College of Medicine, the Global TB Program. She's also the regional study manager for the TB Gaps project that is being conducted in 5 African countries. She's also the program director for the NIH Fogarty D43 Siakula Research Training Program in Eswatini. So her work in clinical TB sequencing, operational research, health system strengthening, capacity building, and policy development continues to advance drug-resistant TB control globally. So it is an honor, Doc, that you have joined us today. And with that, I welcome you and over to you. Thank you.
Thank you, Lucy, and good afternoon, good morning, and good evening, colleagues. I will share my slides. So I'll be taking you through the presentation that is looking at making genomics work in TB. I hope you can hear me. You can always signal if I'm not, Lucy. So I'll take you through the practical approaches and cost-effective use of targeted next-generation sequencing in TB programs. And I'll be sharing through the country context so that at least we understand where we are coming from and some of the rationales for implementation of tNGS. I'll take you through some of the steps, some cost considerations, and the clinical use of targeted next-generation sequencing in country, and the progress so far. So Eswatini is still among the 30 countries with the highest TB HIV burden globally. We have the highest HIV prevalence in the world at 25%. Our MDR prevalence is 5% among new cases, 44% in retreatment cases. We actually have high TB HIV co-infection at 65% for drug-susceptible TB, and for DRTB it's even higher at 71%. We have decentralized our diagnostic techniques, especially GeneXpert. We have the 6-color machines, we have the 10-color, which are the XDR assay. We also have 2 culture labs where we have our midget, our line probe assay, and we have also introduced targeted next generation sequencing where we use the diplets. In terms of treatment, we have decentralized our treatment sites as well as the DRTB treatment sites. We introduced the new drugs, that is bedaquiline and delaminate, in 2015 and 2016. We also introduced our modified 9 to 12 month shorter regimen in 2021. And in 2023, we introduced and scaled up BPAL-M regimen. And over the years, we have seen our incidence rate going down. And if we compare 2015 and 2023, the reduction was by 45%. Unfortunately, we still miss a significant number of our patients with TB. When you look at the outcomes for DSTB, we're at 83%, which is actually below the global average of 88%. And our major challenge actually does, especially among patients who are co-infected with HIV. When we look at the DRTB outcomes, actually we are doing so well in that, and we are currently at 84% above the global average, and also much better than the DS. And yes, our challenge is also deaths, but our deaths are actually lower than those for drug-susceptible TB. So despite all these diagnostic initiatives where we've decentralized, even introduced, we've decentralized our diagnostic techniques, and we have universal DST, we actually have good DRTB outcomes, but we still miss 63% of individuals diagnosed of MDR-TB or rifampicin-resistant TB. So if you look at our treatment coverage, it's actually very low at 37%. It was not until we conducted our drug sense survey that we realized we had a prevalent strain with an uncommon mutation called RPOB I491F. And this mutation actually escapes the diagnostic techniques that we have in the country. That is the GeneXpert, the line probe assay, even the midget. So in the first DRS, we realized that 30% of rifampicin resistance TB individuals were actually missed by the GeneXpert. So in response to that, we introduced universal phenotypic DST using the midget, and we're trying to identify this mutation. Unfortunately, we still missed. So when we conducted the second DRS in 2018, the prevalence had actually increased to 58%. So that meant 58% of true rifampicin resistant TB individuals were actually incorrectly diagnosed as rifampicin susceptible by GeneXpect. Further analysis, it also showed that it was not just GeneXpect. Even the land probe assay, even the midget still missed. And one important indicator for strains harboring this mutation is that most of them are actually identified as isoniazid resistance when you use the midget culture or when you use the expect MTB XDR assay or land probe assay. So what we did, we established a multidisciplinary team to review these DRS results and make sense of them, and also explore any diagnostic options we needed in the country. And we're lucky at that time in 2019, we're conducting a program review. So we happened to have the WHO Afro representative in the country, the lab team, in-country TB program, and the technical working groups. We also had WHO in country with us, so we really discussed in length. So we assessed possible tools. LGA culture was considered. Is it better detects certain mutations, but unfortunately than midget, but unfortunately it still had its limitations. So several sequencing technologies were also discussed, including next generation sequencing, although at that time they were not yet recommended. But a strategic decision was then made. And I think when we were looking at all the possible diagnostic techniques, the team agreed that introducing targeted next generation sequencing offered most promise, although we're cognizant that the recommendation was not yet done. So the decision was made to actually implement tNGS as a pilot project. So we then developed a protocol to guide implementation. We got funding support from Global Health Protection Program from the German Ministry of Health. And then in-country, Baylor Foundation, Eswatini led implementation in collaboration with Baylor College of Medicine. So just to mention that the German Federal Ministry of Health also support two other countries, Mozambique and Namibia. So after our discussions, we had to sign an MOU between the Ministries of Health. We also had to modify our line probe assay room to actually integrate tNGS workflow. We created space to accommodate the equipment, the ISEC 100 and the PCR award. A lot of capacity building and sensitization was done. So our lab team was trained in tNGS workflow and operations. Our clinical team had to be sensitized on the results and the reasons why we're bringing in the tNGS, and also sensitize them on the flow of the specimens to ensure that at least they request for sequencing. We developed an interim diagnostic algorithm, which we trained the team on, emphasizing the reflex testing of second specimen. The project experienced delays due to COVID-19 disruptions and some procurement challenges. Unfortunately, we were able to only implement in 2021. So we had an official launch when we started with high-level stakeholder engagement, and this helped to boost momentum and also catalyze mobilization of in-country resources. So these were some of our costs when we were setting up. So mainly our costs were in the infrastructure, were in refurbishment of the LPA room, in procurement of our equipment and reagents. And then for data management, it was mainly on data storage, data collection tools, and also database development. We received a lot of technical support from Boston team, from Illumina, Milan, WHO, supranational labs, mainly for our lab team. There were trainings on site, there were also remote trainings. And in the first 2 years, a lot of trainings were done. We were experiencing a lot of failed runs, but with time now the team is as well capacitated. And I think in 2024, we only had like 3 failed runs. And then in terms of bioinformatics, we don't have an expertise in country, but we get support remotely by the postal team. And then some of the costs during implementation or HR, we leveraged on the existing staff at the National Reference Lab. So we only recruited 2 lab personnel. And just this year, we added a research assistant who is really working on the data because it was becoming more. So for our trainings, there were also some regional trainings in Mozambique, in Namibia, in Uganda. And we actually hold quite a lot of meetings with our clinical teams so that we keep them updated. Yes, there's also support for conferences. So there's this paper I also looked at. I happen to work with also Prof. Alice Swelling. So she's doing quite a lot of work on costing for tNGS and also supporting the WHO. So I think, I don't know if some of you have looked at it. So basically it was exploring potential cost effectiveness of tNGS for the diagnosis of TB across 3 countries. That is India, South Africa, and Georgia. It was a modeling analysis. So in terms of the cost data, they sourced it from a systematic review, which was conducted to inform WHO guideline development group process. So what came out from this analysis is that tNGS actually proved to be cost effective in South Africa, but not in Georgia. But when tNGS was actually used as an initial test versus expert followed by phenotypic DST, it appeared to be cost effective. But in India, tNGS dominated phenotypic DST. It proved to be very cost effective. But also one thing they highlighted was that universal DST, actually, if it's well established in a country, it actually dominated tNGS. But again, how many countries have universal phenotypic DST? We see that most countries, it's not routinely implemented. There are always some challenges here and there. So maybe if you put that into consideration, then tNGS proves to be cost effective. But one area was also on the reagents and the test kits. So when they had another scenario where there was 50% reduction in tNGS test kits, comparing it with phenotypic DST, tNGS proved to be cost effective across all countries. And it was even more when there's high beta-claim resistance in the country. So take-home messages. I think when we are implementing tNGS, is also looking at the context of the country. Is phenotypic DST well established or not? And also looking at certain issues, which I will highlight in this slide. And thanks to Alice also for sharing this one. So they were looking at major cost drivers that impacts on the cost for tNGS and WGS. So sequencers, the type of sequencing machine, and also the kits are actually the drivers, cost drivers. So those are some of the considerations we need to look at as we are looking at which sequencing machine you would want to procure with your suppliers. And also, if the sequencer is greater depth and also breadth in terms of coverage, it's actually also associated with greater costs. And another thing also that was highlighted is inefficiency initial sample runs. For example, if you have a lot of failed runs, mainly maybe the team is not well trained, this can also result in increased costs. And another area is on batching and multiplexing. So lower sample volumes and less batching increases the cost. So we see countries that probably have the higher burden of MDR-TB, they've got a lot of samples. If they can batch more, the cost becomes lower. If we look at India, I think the situation of India, then also multiplexing with other diseases also makes sense. And for Eswatini, we started with TB, only TB samples, but now we have integrated COVID-19. So these are the sequencing systems we have in country. We have the ISEC 100. We also have the MySeq. So in the interim, we developed an algorithm to guide the eligible samples for sequencing at our lab. And this was informed by our DRS results. And if you remember well, we said one of the indicator was that most of these samples which harbored this mutation had INH resistance. So hence we prioritize any sample with INH resistance or INH polydrug resistance by either LPA or MICHIT. We prioritize for sequencing. And even those with rifampicin resistance by GeneXpect, we still did tNGS, mainly because our phenotypic DST is not done routinely. And also the fact that we only managed to do DST for 4 drugs, and for tNGS, we are able to do DST for 13 drugs. So yeah, we didn't want to miss that opportunity. And also during treatment, we looked at patients who were not converting at 2 months or those with a culture revision. So those were prioritized for GeneXpect. So basically when we started, we actually looked at the first 85 samples that were analyzed by the team and were successful in terms of the runs. The team picked up that, yes, they are able to pick up the mutation, the RRPOBI491F mutation, but of concern was that there was now additional resistance to beta-clinclofosmin, like quite a large number, like 76% of those. So this was then communicated to the National TB Program, and we had a meeting with the technical working group where we realized we even had a bigger problem here. And a decision was made to use these pilot results for clinical management. So to guide this, because it was still new, we needed people who could interpret well these results and ensure that really there is resistance. And also look at the regimen that the patient is taking and advise on exactly which regimen the patient should, looking at the clinical information. So we set up what we call the Clinical Advisory Committee to guide optimization of this treatment. So this team has clinical, laboratory, and public health expertise. It includes in-country experts as well as international DRTB experts. So from these results, we managed to follow up 37 patients, and we collected clinical information for these patients, and we compared with the tNGS results, and we submitted to this committee for treatment guidance. So basically, in terms of the age range was from 14 years up to 76. And majority of these patients were actually HIV positive, 70%. And also, we could see that about 62%, which was quite a big number, were new patients, never been treated for TB, and they're coming in, they've MDR or they've MDR plus beta-quinine resistance. And when we also looked at the rifampicin resistance detection across the different tests, that is the Expect Ultra, LPA, and phenotypic DST, we could actually see that tNGS detected more, like an additional 46% of patients with rifampicin resistance were actually detected to have MDR TB. So when we were looking at their baseline classification in terms of resistance, we saw that a large number were classified as INH monoresistance by either GeneXpect or line probe assay. But now when we compare with the tNGS results, there was a major shift. So we see patients who have INH mono shifting to either MDR plus PDQ or shifting to MDR, although we still had a small proportion that still remained as INH mono resistance. So one thing I also wanted to highlight is most of these patients who come with MDR or beta-quinine resistance, they did not have fluoroquinolone resistance. And we know in terms of our classification recently, it's more of a pre-XDRA, you need to have fluoroquinolone resistance, but in our case, there isn't. So we just classify them as MDR plus BDQ. We actually had a few with fluoroquinolone resistance, which we classified as pre-XDRA here. And when you looked at the clinical outcomes, so when these patients were followed up, we managed to change 73% of the regimens. And the main change was around RHZE. So they were changed to either bedaquiline-based regimen or individualized regimen. And the treatment outcomes were actually, the treatment success rate was actually 84%. So for our context, really, we saw that tNGS really played a critical role in clinical management. We managed to get precise diagnosis. We managed to optimize the treatment for our patients. Our healthcare workers were actually capacitated. In terms of the public health point, we managed to minimize the potential threat of this spread of these severe forms of DRTB. And it also actually led to tNGS being integrated into our diagnostic algorithm. So far, we have actually integrated tNGS into our national diagnostic algorithm. So this is our algorithm. So basically, we collect 2 samples from our presumptive TB patient, and one goes for GeneXpect. One sample goes for GeneXpect. If MTB is detected and rifampicin resistance is detected, we start that patient on DRTB treatment on shorter or oral regimen, basically. And then the second sample is sent to our national reference lab, where we do culture, phenotypic DST, and targeted next generation sequencing. And if MTB is detected, rifampicin resistance not detected, we put the patients on first-line treatment. We still send the second sample for tNGS, for culture and phenotypic DST, and also do the targeted next generation sequencing. So this is our database. So when I just filtered those with the I491F mutation here, just to look at the resistance profile across all modalities, we could see that if it's an LPA, they are picked as rifampicin susceptible, yeah. And phenotypic DST, yes, they are still picked as rifampicin susceptible. Yes, we have others that are not done or indeterminate. But in terms of isoniazide, there's CAT-G mutation. But here now, when you look at the tNGS, they are actually picked up as resistant. So yeah, really I491 mutation is still being missed, our diagnostic techniques, and is only picked up by tNGS. And we also looked at about 427 samples from our lab, just also looking at the resistance profile. So out of these 427 samples, line-probe assay picked up 66 to have rifampicin resistance. The midget picked 92, and tNGS picked 182, which meant about 50% of the rifampicin resistance samples could probably have been missed if we didn't use targeted next generation sequencing. And then we also looked at the INH resistance, as we had highlighted that some of them will be picked as INH resistance. We wanted to know if those who were initially classified as INH monoresistance, how many eventually changed. So we saw that from this 79% classified as INH mono by LPA, only 21% were true INH mono after tNGS. And from these 182 samples that were also picked up to have rifampicin resistance TB by tNGS, 73% of those had I491F mutation. And out of those with I491F strain, 82% actually had bedaquiline and cofacimine resistance. And we still see that fluoroquinolone resistance is actually very minimal. We only had 8 samples. So just to also share some work on Stool, I know there was also a question around that. We have also done tNGS using the Stool sample. And we know very well Stool is an important specimen, especially for populations that struggle to produce sputum, especially children and people living with HIV. But we know that currently the recommendation is among children. So from this study, it was done among the adult population, but it also included people living with HIV. Unfortunately, we didn't have kids in this cohort. But we can see from this data that tNGS is actually quite useful in stool when the PCR is positive here. We are able to detect resistance, but when it's negative, really, we could not detect resistance. But there's also need to do head-to-head comparisons between tNGS on sputum and stool, just to get more information. So you can actually check Sibans et al. For this paper to get more information on it. And another recently published paper is by Tara. Maybe Tara is also joined. If you also need more information, I'd ask you to do. She also assessed the ability of nanopore. I know we are using duplex in country. We also have nanopore in our research lab. She also wanted to see if using stool could detect also drug resistance. So she looked at about 57 patients. The age range from 2 years to 8 years. So at least this cohort had kids. And also in terms of people living with HIV, we had about 45%. And they managed, the team, to detect 14% with drug resistance. And another also addition was that they were able to pick up those with RPOB491F mutation. And we could see that if with actually stool, we're able to change regimen for some patients who probably would not have been picked up without tNGS. And also an advantage of nanopore is the turnaround time. It's actually 46 hours compared to maybe duplex, about 48 hours, yeah. So in conclusion, tNGS, really, we see it as a powerful tool for rapid diagnostics of drug-resistant TB. And it actually offers advantages in terms of speed, in terms of cost effectiveness, depending on the context of the country, and also comprehensiveness, because you are able to test about 13 drugs vis-a-vis probably for phenotypic, about 4 drugs at that time. And for Eswatini context, our prevalence of RPOB491 mutation is high. And without tNGS, would miss more than 50% of those with rifampicin resistance, because other diagnostic techniques still miss these patients with this mutation, leading to suboptimal treatment. And the additional resistance to bedaquiline and clofazimine makes it even more challenging, especially in the context of BPAOM regimen, emphasizing the need for integrating targeted next-generation sequencing into national diagnostic and treatment algorithms. And I think Eswatini has done a good job in doing that. And for sustainability, there are a few things we are looking into. There's need for capacity building, continued capacity building in tNGS to the whole team in the National Reference Lab, in wet lab, and also bioinformatics. Yes, we are cognizant at the moment. We receive support remotely, but I think it's something we also need to work on, and also ensuring that we transition procurement of reagents by the government in a phased approach. I think this is also one area. Reagents are quite expensive, and also from the systematic review, one of the cost drivers. And it's also very important to ensure that integration continues with the existing sample referral system, strengthen what we have, and don't parallel system are never encouraged. It's important to integrate. So I just want to acknowledge the Ministry of Health, our implementing partners who are supporting implementation of tNGS, our healthcare workers, and our patients. And special recognition to Mangaliso Ziani, Dr. Alex Leonardo, and Professor Alice Swelling. We have been helpful in coming up with these slides. Thank you.
Yeah,
Thank you so much, Doc. This was really a brilliant talk. And I think you touched on all the points that have been coming up during the series, particularly around costs and cost effectiveness. So that is really great. And I think something that I picked up from your talk was how collaboration between the researchers, the clinical team, and the National TB program was essential to ensure adoption of this new technology? Because you started implementing even before the WHO recommendations came, although because of COVID, then there was a delay. And by that time, we sort of had some data coming through from WHO. So I think that collaboration between the academics and the researchers doing the work and the National TB program, allowing that early adoption of this technology that is clearly helping improve the outcomes of your drug-resistant TB patients is crucial. So I think one thing I just wanted to find out from you, what drove the selection? I know you mentioned you're mainly using diplex, and in the research setting you have nanopore. So how did you make that decision on which technology to select for your implementation? Over. You're muted, Doc.
Thank you. So we selected diplex anyway because it was approved or recommended by WHO. So we went for that. So for nanopore, we use it for research, but we are cognizant because of its turnaround time. So there was a team that also wanted to see if it works well and if it's something we could consider. So yeah, we went for that.
Great. And I think just as a follow-up to that turnaround time question, I noticed on your algorithm, you mentioned something about a second sample that is then sent for testing. I know in some countries they have challenges where they collect a sample and for diagnosis and then another sample for phenotypic DST, and then that's then done at a later stage depending on the diagnosis results. Did you have any issues with storage of those samples on site, and how did you deal with those logistics? Over.
Yes, thanks. So basically, it's as part of our algorithm, we collect 2 samples from the wait-go. So those 2 samples, they go to the Genomics site. So it's now up to the lab. If this sample is MTB detected, whether rifampicin resistance detected or not, there's a reflex now. The second sample then goes to the National Reference Lab. So to reduce that delay, we make sure 2 samples go. So yes, we actually have maybe some patients who probably would not produce 2. It happens, but people know that at least 2 samples have to go to ensure that. And because we were encouraging universal DST, but it's unfortunate, even if we wanted universal DST, still the midget had a gap in terms of the mutation that we had. But now we are happy that that second sample then goes for tNGS. Yeah.
Great. And then have you looked at the time it actually takes to initiate a patient or treatment? I know you've been talking of the reduced turnaround time on the testing side compared to perhaps maybe 3 months or so that you would need for phenotypic DST. But have you actually looked at how that is improving the time it takes from when a patient first visits the clinic to get screened until they're actually initiated on the correct regimen?
Yes. So with the Genomics, because the patient gets the results on the same day. So in terms of MDR or drug-susceptible TB treatment, it actually happens within 2 days. I think from our program review, if probably we are at a clinic, it would go up to 7 days, but within 2 days, patient starts, I think majority of our patients. But now when it goes to the National Reference Lab, where now another test and another DST has to happen, that's where now the delay is. So in terms of our tNGS, we usually get our results by 2 weeks in the lab. So 48 hours, like, yes, it happens in 48 hours, but because of batching, it takes about 2 weeks. Yeah, because we don't have many samples. But then there's also the interpretation part that happens because we get remote support and it usually stretches to a month to get those results. It used to stretch to about 2 months when we started because of the failed runs but I think with time now, when we don't have many failed runs, at least I would say up to a month. Although I know the team is working on analyzing that to look at the trend over time, because we have a manuscript that we are working on just to look at the progress so far. Then with phenotypic DST, because yes, the results will get them after 6 weeks. In general, in our setting, we would get results after 2 months and sometimes after 3 months to make those changes. So we'd see that patients would probably be on suboptimal treatment. So when we compare with tNGS in our setting, we feel tNGS is probably better, or it's going to improve our outcomes if we are with strengthening the systems, especially the sample referral, and there's actually progress in that area. Yeah.
All right, thank you. And I see a lot of people are raising their hands. If you could please just put your questions in the Q&A box and we will get to them. So I see there have been quite a few questions around supply chains. There's a question about how have you convinced the government or the funders to buy these reagents, because they seem to be very expensive. And then a follow-up question on whether supply chain challenge, if Eswatini faces any supply chain challenges, and if you could speak to some of the lessons you've learned in that. Over.
Yes, so supply chain challenges as a whole, yes, we have challenges. That's why, especially even for our phenotypic DST, it's always on and off. At one point we're doing, sometimes we don't, because of that. So we still face the same challenges with other countries. Then in terms of tNGS, because we are being supported, so it was a bit stable because of that. But now we're now advocating. So mainly because when we got these results, we also share with the policymakers to show them that really this is something we need to consider in terms of tNGS. And also we advocated that it's part of the diagnostic algorithm. I think that was important. So that meant that now as the government, because it's now part of the diagnostic algorithm, that means in terms of the reagents, they need to be considered. But currently we are being supported by Global Fund. I think that was our first step, to include it in the Global Fund. And then the way we are seeing it is just we need to do like a phased approach. When it's under Global Fund, it's the government anyway. So with time, we hope that transition will happen. So I think in our case, we managed to justify this, and they could see that we have a challenge. What I can say is we didn't have a choice because we're missing a large number of people. So we needed to just implement tNGS, which comes with reagents. And I'm thinking for other countries, if your phenotypic DST is probably working well, probably now you would need to justify in terms of why this is cost effective vis-a-vis. So I think that work that is being done really will help a lot of countries. And also thinking around where tNGS should be would also help in terms of this cost effective analysis. Do we want to put it after expand? Do we want to put it before and LPA coming in, do we need to remove it? So yeah, there's a lot to it. Thanks.
Yeah, and I think you've just brought in an important point that each country is going to have to look at their algorithm and their TB diagnostic network and figure out where it would be appropriate to put tNGS. But what's coming from this talk is it's important to make use of the tools that we have available, and realizing the challenges really that many of the countries have been facing with phenotypic DST. Considering tNGS is actually a great option. So there is a question that's coming in around the extraction processes. So they said, could you clarify how you've isolated? Do you start culturing the sample, then isolate the DNA extraction for tNGS, or are you testing direct from sputum or from sample for both the stool and the sputum?
Okay, so I will start, but Mangaliso, if you really want to explain the extraction process, he's online, he would. But basically we do direct on direct sputum for those that are smear positive, basically. And then, yes, then we do culture first for those who are smear negative. I know when we started, we were doing culture because we didn't want field runs, but with time we became confident. So we're prioritizing those with smear positive, we do it. Negative, then we do the culture first. I don't know if Mangaliso is online, would want to add on that.
Mangaliso, I've allowed you to speak if you want to add some detail.
Okay, good afternoon, good morning, good evening, everyone. Yes, in terms of the DNA extraction, so we are doing the sequencing both from sputum and also from cultures. So for the sputum, direct sputum, we use the alcohol precipitation. So we start with genolyze, then we do the alcohol precipitation, then we do the duplex. Then if it's from cultures, we use CTEP DNA extraction, because we also use that DNA for whole genome sequencing downstream. Then for stool, we use the MP fast method for the DNA extraction. I hope that explains it. Thank you.
It does. Thank you. Thank you, Mangaliso, and for that clarification. And thank you to the person who asked this question. And I guess just to clarify, Dr. Wambi, I know this was mentioned in our earlier talk, but if you could explain to this participant who is asking, did you target only RPOB or multiple genes? And did you construct your own probes or did you use commercial kits? Over.
Okay, we didn't just target RPOB I491F mutation. We were looking at the whole. We're targeting all the 13 drugs, not just the one for I491F mutation. I don't know if Mangaliso you want to add.
Okay, thank you very much. Thank you very much, Dr. Wambi. Okay, yes, for we target all the 13 drugs like Dr. Wambi has mentioned. So the duplex kit is a commercially available product. So we did not design our own probes or primers. So they come with the kit with like the target to all or to 14 drugs, all the first line drugs, and also this new and the repurposed the second line drugs, including bedaquiline, clofazimine, so linezolid. So basically it comes with the kit. Yeah.
Thank you so much. Yeah, that's great. Yeah, that's great to clarify. And as a follow-up, someone is asking about the RPOB I491F mutation, whether it would have a resistant or sensitive phenotypic DST. And I think you mentioned it in your talk, but if you could clarify that.
Yes. So the RPOB I491 mutation, it will be susceptible by GeneXpect, susceptible by line probe assay, and still susceptible by phenotypic DST. If you remember, we used the liquid media, we used midget. It still was missed. I've also shared the data from our database, where it also showed susceptibility to all. But when you use the tNGS, it's then picked up to be resistant. So I guess that also made us to implement that widely or include it in our diagnostic algorithm. Yeah. But I think data says if a solid media LJ could pick it up, but not entirely, but could pick some. So I guess for us, we're like, do we really want to go for picking some or rather go for a diagnostic technique that picks probably majority? Yeah.
Mm-hmm. That's wonderful. And I think just as a follow-up, if this is being missed by all the tests that we have access to, your LPA, if for people who don't have this setup or are thinking of setting up, at what point do you suspect that this is the individual that likely you should test in case you are missing, or would this now mean that we need to just test all people with tNGS? I'm just trying to help someone who might be thinking through. So what's the take home from this? Over.
Yes. So for us, we're guided by the DRS. So our DRS results, because we also included whole genome sequencing, so that's where we picked up that, yeah, we were missing because WGS told us that we had more. And then now we're looking at further analyze to see for those that we missed, how can we pick them up, like some characteristics. So from that data, it showed that those patients actually would have INH resistance if you did LPA or if you did phenotypic DST. So these are the particular patients you do look out for. So even before we implemented tNGS, remember it took us time, we revised our guidelines and sensitized our clinicians to look out for those patients with INH resistance. To either by 2 months, if they don't have any results, they would actually empirically initiate these patients. And when I was actually looking at the data, I could see empirical treatment, like those written presumed MDR going up over time. So it was like, yeah, I think it's getting there. People were like vigilant, trying to look out for those ones. So those are the things I could also say, let's look out for those INH, but DRS results are the best. Ensuring that you have also strengthened your surveillance is also important to be able to pick up some of those. Yep.
And it's great that you've talked about WGS whole genome sequencing, because there was a question that how does tNGS compare with whole genome sequencing, particularly in resource limited settings?
Yeah, so when you compare, WGS is very expensive and resource intense. Although we know you're testing the whole genome, you're going to pick everything, but now when you compare in terms of the cost vis-a-vis, you see that tNGS probably would do better. And really 13 drugs, these are almost all the drugs that we use. Somehow we, in resource limited settings, I would say would go for tNGS or genome sequencing, mainly maybe for surveillance, not for clinical management. So I think, yeah, it's better to introduce tNGS for resource limited settings.
And then as we wrap up, we have a question around data storage. And this individual is particularly interested in accessing your work, and they're asking, are there repositories where you, for your data storage that researchers could access? And I think as a follow-up to that, a question that was asked in an earlier session was just how do you then ensure your access to that data? If you're publishing your sequences online, how do you ensure the privacy and equitable access of that data as well? Over.
Yeah, so currently, yes, we are using RedCap, and we haven't published on some of this work, and we are working on our paper. But yeah, when we publish, we are going to allow, I think, people to access some of that. I think maybe I would say look out this year. We will also share some of that. Then in terms of whether you also want to do a study, I would say maybe you can reach out and see if this is the team would have to see if it's something they can consider. But I know the people in country, they want to write a lot. We're actually exploring but yeah, so anytime this year, you could also probably have access to some of our data if you want to do some research. But I would always say reach out. We can always work together. If you have a topic, especially when we share this data, you might have a topic that you are thinking of, that if you thought of exploring this, I think we are welcome. We also want those ideas. So please reach out. I think Lucy is my number, and then we can talk.
All right. Thank you. And I think as we wrap up, the final question coming in, you mentioned something about access to bioinformatics support remotely. Do you now have the support in country, and what could be your thoughts on how we can increase that bioinformatics ability on the continent?
So in country, we don't have expertise. I think it's also something we are looking into. We actually receive support remotely from the postal team. that is also supporting us with implementation of this. So what I can say to countries, I think it's one area we need to advocate for, but it's not something that could stop you from implementing tNGS. You could still start, get that support remotely, and then work towards having one in country. Yeah, I think those were the things we were also worried about when we're implementing, to say, in terms of interpretation, what happens, but to tell you the truth, it has made it easier, and also maybe setting up the clinical advisory committee for us has helped, because those results come, they help each other to interpret, we interrogate, they explain to us, and I'm able to even explain to the clinician what does it mean. And we also developed some templates where we already send these results already interpreted in a way that the clinicians can understand, and then they can better manage the patients.
Yeah, and I think also having access to the WHO mutation catalog would assist with some of that interpretation. That this is also something Dr. Chikuse mentioned on the first call, just to say with the sequencing capacity that is on the continent, there have been a lot of regional hubs that have been set up for excellence. So I think if countries came together and see how they could access the bioinformatics expertise that is already on the continent, perhaps not in your country, but if it's available on the continent and through Africa CDC and through countries like Eswatini, Mozambique, South Africa, that are already implementing tNGS, then there could be a network of support within the continent. So in the next 2 minutes, would you just give us your closing remarks on some of the key things that you think countries should consider as they implement tNGS?
Okay. So thank you very much. So what I can say is tNGS is a critical tool, and it's something that countries should consider. Then as you consider implementation, you need to look at your diagnostic algorithm and decide where you really want to place your tNGS. And it should also be informed by your data. If you have conducted DRS, it also helps. And if you also have like routine surveillance, it also helps. And also looking at the outcomes of your patients, seeing what is happening could also help you to see where you should. And another thing is also the turnaround time. Yes, phenotypic DST, if it's well established, I think that's good. But we understand in terms of turnaround time also vis-a-vis our tNGS. tNGS is, the turnaround time is good, but also that also depends on the batching. So I think considering the context is also very important. And also ensure that we align with our in-country diagnostic algorithm. We strengthen the existence. Multiplexing is also very important. With other diseases, it also reduces the cost. If you have seen the cost drivers, if you can batch many samples, if you can multiplex, it reduces the cost. So I think those are other considerations we could look into. Let's see how we advocate for our government to ensure that at least they buy the reagents. I understand it's expensive, but that's where we bring in our data and convince them and advocate. Yes, thanks.
That's wonderful. I like that closing remarks, data-driven policymaking. And thank you so much for all the work that you've done. And thank you again to everyone who's joined the session. Join us again on the 26th of June. We'll have another country experience from Mozambique, telling us how the rising cases of bedaquiline really make a case for using targeted next generation sequencing in the TB programs. I apologize, I understand the Portuguese channel was not working, but we hope in the next series we'll have that sorted. So thank you again, everyone, for coming. Good evening, good afternoon, and good morning from wherever you're joining us. Bye.